Welcome back to Mostly True Psychiatry with me, Dr. Mellon. Thank you for joining me. This is going to be a series of videos I'm going to do on the mental status exam. The first video is going to be a history from Dr. Google, searching it, looking at the archives of old books and stuff I can get a hold of, and then just current books that I have and some of the other residents that I borrowed them from. The next video will be on a basic idea of how you can use the mental status exam. I'll keep saying MSC for that. The MSC for real world situations, how it's different, how you use it, what it is, what it's not in reality. And then it'll probably be 2 videos to go over the actual nuts and bolts of mental status exam, so you can go, okay, what's appearance, what's behavior, how do you do this, blah, 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 and all the neuropsych stuff. So with all that said, let's get started. So prehistory of the mental status exam, prehistory is before, 1899. It's not obvious that anybody should get real credit for anything ever, because basically they're writing stuff about people and situations of what they were considering mental disorders or defects, and it was all personality disorder, and it was all women are crappy and men are acting like women and you're all hysteric and buckle up kind of garbage. So it's not sure what they were even looking at or measuring or how relevant that is, and so everybody wrote about patient history at some point. That's fine, but they didn't have a good idea about it until Mr. Kraepelin, I think, is just a starting point for everything in psychiatry. Now, there's some other ones, but he's pretty good. So he published a classification system that emphasized systematic observations being placed into symptom complexes, which some of it not only looks like the mental status exam, but we're using the exact same words. And 2 years after he was doing that, Dr. Sigmund Freud was doing his stuff and, using cocaine, and everybody has hysteria, and got his cult started and everything. So his version of doing this back then, this is just to be obnoxious, but this is the kind of stuff he's writing at the same time. I just grabbed a paragraph from his book. So it's this is his idea of reading into people's mental status kind of pieces. This is his on dreams. In fact, however, the dream work is only the first to be discovered of a whole series of psychical processes responsible for the generation of hysterical symptoms, of phobias, obsessions, and delusions. Condensation and, above all, displacement are invariable characteristics of these other processes as well. Modification into pictorial form, on the other hand, remains a peculiarity of the dream work. If this explanation, he's a bad psychologist / philosopher. He had a cult. 2 years earlier, this is what Kraepelin was doing. So this is from his textbook. He had it was kind of published for multiple people for 20 years, right? So this is what he wrote 1 or 2 years before that other stuff. The chief symptoms usually appearing in the manic phase are psychomotor excitement with pressure of activity, flight of ideas, distractibility, and happy though unstable emotional attitude. In the depressive phase, we expect to find psychomotor retardation, absence of spontaneous activity, dearth of ideas, and depressed emotional attitudes. This sounds way more like what a mental status exam actually is, in practical use nowadays at least. Kind of the real starting point everybody likes to point at is this guy, Adolf Meyer. He was a big shot at Johns Hopkins, new fancy, school, lots of money, super important, all the glory. So people pointed to him. In all fairness, his book and his ideas, they 50 years of presence in psychiatry, easy. So he's credited with coining the term mental status. So, it's good for him. He promoted a narrative style of the mental status exam, and really a lot of focus on psychosocial, sociological kind of thing mixed with biological format. Didn't research it, but I would guess that was a big department there. That was a big time frame for it. Just everything had to do with Darwin right after Darwin. So it's all how do we shoehorn this into everything? It's the new bestest thing ever. It's artificial intelligence right now. It's that kind of same thing with computers. But so he put a lot of work into doing a good psychosocial history. I mean, he did a solid job. he wrote about, the next few slides will show where he really went into depth with specific, whether it's good or not, that's going to be part of the arguments for 40 slides to come. But some people try to give him credit for like the biopsychosocial or something. And, I found a piece from a couple years earlier, right? Like a few years, maybe like 1680 or something. Like George Stahl, like a German chemist and philosopher, was already made a lot of the same basic arguments for the biopsychosocial, and that psychiatric issues should be looked at as a combination of their psychological, sociological, and biological. So it's the great man theory garbage where we just look for some superhero and everybody say, ooh, but for them nothing would have happened. It's everybody has these ideas. They're not new. People had them 2,000 years ago in China and the Middle East, wherever. Just somebody wrote it down that you can read. So Adolf Meyer, it was really thorough. So like as an idea, basically it was kind of this big division. It's family history, so it's the people around them, and then their own history. So like family history, you want to know about their diseases and deaths and birth order and marriage and relationships and who liked who and physical ailments and and on and on and on. Everything about the family. So good, solid. Then there's a personal history, which was everything, your medical history, your psychiatric history, everything. So and it was very, very thorough, and it probably matched the thoughts of the day, right? So prenatal history, birth history, by developmental stage, how are they doing in early infancy and childhood, etc. What were their school experiences like, their adult life, medical history, somatic complaints, and they just kind of start throwing in some of the like hysteria type things, or just trying to get some of the pieces of psychiatry actually shoehorned in there eventually for medical. But there wasn't a lot back then, right? Yeah, the DSM-1 and 2 in the U.S., and that was, by the military, that was questionable as helpfulness. So I put this picture here for it because I went to what's it called? There it is, Internet Archive, and if you just search on Google, like the collected papers of Adolf Meyer, you can find the original book, and I was able to check it out for like 2 hours so I could read the pages that actually had to do with the mental status exam. It was a book that it was a collection of his papers, and he was giving presentations to the medical students or whatever, and they put him into a book. So I guess that's how he practiced, or his ideas too. These are some kind of pictures and ideas. So family history, he was serious. There's like the genealogy thing, right? And you start mapping that out. And then this is just like 15, the first 15. This went on for pages. I don't know how many there was, 50, 500, something. But it was just detailed history of people, right? So I don't know, pick a number, 1 to 10. We'll go 8. Okay, let's say number 8. Fears, hysteria, nervousness, distinct attacks of nervous prostration. Because back then, women were all terrible, and they go, and they'd freeze and fall down because hysteria was real. And then, it's apoplexy, senility, imbecility, epilepsy, age at marriage, blah, blah, blah. Just a long, long history. It went on like this for pages, but it's all good stuff. And then he'd do kind of like his little timeline picture, and, by year, what was going on, and, they had illicit relationships in 1913, and then 2 years later, depression's a problem, right? Like, it's good. It gives you a way to visualize it. This is a big push that they do, particularly for bipolar mood disorder type 1, right? It's mood mapping. It's been an issue. It's been attempts and variations written in books for 50 years, at least, on the topic that I can get a hold of. Oldest actual textbook I got a hold of, because it was free and I could find it. It was from 1943. Pretty old, There's a link, you can get it online. It's downloadable. It was the 3rd edition. It wasn't even like the 1st or 2nd. It was pretty, but you kind of see on the right side the mental status exam. Its synopsis. It was already doing a decent job. It was trying to put stuff in boxes and categories, even if we don't use them quite that way. But like 1 and 2 would be attitude of their general behavior, how they normally act, and then how do they act during the interview, that kind of stuff. Because they were concerned about people. It doesn't matter. We'll drop that stuff. I don't need side tangents. They loved reactions. Everything was Freud, right? So psychoanalysis, so emotional reactions. They do a cognition kind of testing and stuff. That's their sensorium, mental grasp capacity stuff. So reading, writing, recent history, that kind of stuff. And arbitrary just examples here. When I was going through the book, but. A lot of things you think of were there. So, it says general mood, and then they gave you examples of mood. Were they apathetic, calm, depressed? Speech, and they give you speech terms. Was it normal and spontaneous? Were they mute? Were they stammering? Were they slurring? Kind of how they looked, what they're doing, or their attitudes towards the interviewer. They did facial expressions for affect, and then they give you options, to use. Motor activity, largely different, but, we kept it. Gaits, gestures, general activity. And then they had some of the terms were there, right? Psychomotor retardation from Kraepelin from, over 40 years earlier. And then negativism, catalepsy, some of those ideas. So this was, again, 1943, so this is schizophrenia with no medications too. So you have, all those things matter, right? So certain things you're saying, it's relative to when it was appearing. So they didn't care about the Ames test back then because nobody was being locked up by, Haldol and stuff. So they could see if the drug worked. That's how they used to be able to tell. Neuroleptics worked because they could lock you up, and that was the good stuff. But those things actually were, spontaneous back then. Without medications, people would still have, people with schizophrenia would have a lot of the same neurological reactions, other than just the stiffness. Then there's like verbal stuff, language stuff. Then they'd start going into how they were looking at hallucinations and delusions, and they spent a lot of time there. And so, they were real big for a long time, all the way up through the DSM-4, right, of going, oh, is it a persecutory delusion? Is it this? Is it that? Are they thinking about witches? Are they thinking about being naked? Are they thinking about being, it's like, just whatever, it's a delusion. It doesn't matter what it is. Back in the 1700s, they were all witches, and computer chips became a thing, nowadays, like whatever. It's not a computer chip delusion or specialty, but they spent a lot of ink on it back then. They still do in a lot of books. So then we get up through the 1950s, and people are really trying to look back at the mental status exam. They're cranking out papers and like, how do we do it? How do we do it right? We're getting ready to go to the moon in the next decade. We're solving everything in the world. Computers are going to be out there, robots in space, television, all that good stuff. So what were they doing back then trying to figure it out? Well, they noticed there were lots of problems with the mental status exam. Super obvious back in the 1950s that kind of the things they were talking about would be like, there's no even like theory to what you're doing and why, like what sections are you adding or why are you keeping certain pieces or removing pieces, there's no theory, just preference. There are many authorities on that were, widely used and talked about and stuff, and the number of sections in that mental status exam would go like 6 to 14, and magically, the newer the one you were, it always got to be bigger and more, because that means better, bigger, more, better. So they just kept cranking out more and more sections and saying, look how great I am. I can do a better job on this. There was no research evidence about why you're including sections or why one would be included and not the other. They were just cranking out research going, look, you include this, and I asked patients it, and there's an answer. It's just using it and just called it good. The sections of the mental status exam aren't like made to where they make sense together or they interact with each other or one's relative to the other one. They're just little silos just shoved into a piece of paper. Not typically back then, 100%. They're just narratives. They weren't reliable. So you'd get two people, they interview the same person, they write something else down in the same section of the mental status exam. It wasn't applicable to research because it was just a narrative, and they didn't track changes over time. It wasn't quantitative. And the quality of the mental status exam magically matched how much time you spent with the patient. Short, useless mental status exam. Way too long, don't care, useless mental status exam because you're a professor at Hopkins and writing 900 pages and have 4 hours to do your psychoanalysis on a patient. Yeah, it doesn't work in the real world. I'm glad rich people get rich stuff, but that's not helpful or useful in the real world. So then one paper's back in the 50s, they're like, we got computers, or probably back then, right, punch card something. They were like, we can factor analysis stuff. Maybe they'd do it on paper. That'd be the worst. So they made all these arbitrary groups of factors and things they could ask, and, like, are you a deviant homosexual? And then they would rank them and figure it out and go, oh, you're depressed because you're a deviant homosexual, or, whatever came out of that kind of garbage research. But that idea of actually asking fixed questions in a certain way and seeing if you can get a diagnosis out of it was super useful to Robert Spitzer. So he was part of the coup that changed the DSM, right? So they came out. It was basically like 3 people, and they did a bunch of research diagnostic criteria stuff, put together groups, try to figure out how we can actually make real diagnoses that you could test and do research on, and it means something, and it's not just a reaction. And they just flipped the whole DSM in one edition. So he liked this factor analysis stuff and did a paper on it. So it was about 5 years later, kind of, and he cited the other paper and stuff. That's kind of how I found these things, right? You look at one paper and then you go look at their sources. So there's like over about 5 years from the 50s to 60s, there was like 4 separate papers that were like seriously critiquing and trying to figure out what to do about the mental status exam, and they're all saying it's bad, it's not reliable, it's not helpful for research, what do we do? One of them was Aaron Beck, 1962. That man wrote a paper in like 2001 or 2 on cognitive behavioral therapy, for those who don't know, CBT guy. He wrote a paper like 2001 on schizophrenia for MSc. So he did this for 50 years. But he demonstrated that the variability in the mental status exam back then was atrocious, and it just produced disagreement. There's no way to know what the hell they meant. And continued to make standardized MSc questions and try to make it where you could actually use it for research and that kind of stuff. And then Spitzer took it to the nth degree. He made a paper with 82 specified questions for the mental status exam to do, and 51 follow-up questions in case you didn't answer it the right way. When you get the basic thing is, how are you feeling? Fine. Like everybody, okay. You get those generic answers to everything. And he said he promoted natural language when he was doing that, and he wanted it to be a normal, like where it would flow as a conversation, and not use lingo that's in the field, and to use kind of general identifiers like the symptoms of depression. So if you said, I feel low mood and have no energy and I don't want to do anything that I used to love doing, anhedonia, you get those little check boxes off, and then boom, it pops out, depression, major depressive disorder. And he strongly agreed against a lot of the terms, because back in 1964, it was super obvious. None of the psychiatrists were actually agreeing on what the terms meant that we're still taught, like circumstantiality, that they could get several psychiatrists that same interview, and one person was like, it's circumstantial, other one's like, you're psychotic and tangential or whatever. Like, it's just, there's no consistency. So, it's fine. We have lots of these terms, but utility is the tough part. So this is parts of his paper, right? So mental status exam on that side right there. It's pretty short, right? It's nicer. It's appearance, attitude, spontaneous behavior, language and speech. He did psychotic signs, non-psychotic signs. Okay, there's the buckets to cover everything. Sensorium, insight. I think I just write cognition, psychosis, non-psychosis, or mood. You just cover it. I don't know. It doesn't get behavior and stuff, but I tried. He gave something, and then in his naturalistic language. I mean, you're going to go. Now, I would like to hear about your problems or difficulties and how they led you to coming to the clinic. What kinds of moods have you been in recently? What kind of fears do you have? I don't know. It wouldn't work for me, but I guess others. To each their own. So let's think about it for a second. This is going to be a pause moment. I'll ask you a question. You can pause the computer and decide if you have an answer. So everything has two sides. I never believe in extremes of anything on all this stuff. It all has partial truth. So what are benefits of making a mental status exam more standardized, right? There's going to be pros and cons. There's going to be benefits and negatives. So what are actual benefits of standardizing it? And give you a second. Let you pause. All right, for those who want to do it, congratulations for using your brain. For those who didn't want to, here we go. It does promote research, because you actually have quantitative, qualitative, real words, consistent words, that kind of thing. So it does promote research. It's more reliable and valid, because at least you're looking at the same thing and you're talking about the same thing, which makes it more scientific, right? It's easier, faster to learn. It should be, because that's part of the problem right now. You're like, I know the mental status exam, and then you get taught something that by the end of this, you'll have a better picture of what it is you're looking at. But nobody will give you the real mental status exam. And you looked in the DSM, you're like, Where is it? Where is it? Where are the list of the terms that I'm looking for? It doesn't exist. That's a problem. This is all fake, and people are pretending like it's more real than it is in certain ways. All right, this is a pause moment. So, what are cons? What are reasons against making the mental status exam more standardized? Give it a few seconds again. Bounce around. Okay. So, negatives could be that researchers have agendas, they have goals to what they're doing, they're p-hacking, you have no obligation to help them. If you don't realize that yet, hopefully you do at some point in your career, that just because somebody puts something in a journal in science, especially in our field, does not make it true or real, or anybody else's field. But they couldn't reproduce a lot of cancer research, let's be honest, in this stuff, and you think that stuff should be real. I don't know about you. I don't want to feel like a robot. I don't want to just, I feel like or at least I don't want to go through 40 years of education and then I have to read off a standardized list, but maybe I'd be a better doctor for it. Who knows? Anything that's standardized is gameable, so malingering becomes an issue. Kind of following that as the last point. So if there's a standardized format and it's gameable or these things, so if they answer questions in a certain way, then that could make you put a diagnosis you don't want to, but not making that diagnosis in that situation would probably be considered a deviation from standard of care, and the APA will not support you, and AMA will say you're a bad person and you will get hammered and fined if someone attacked you because you're not following the standard of care. So that's another problem. Time's always at the premium, so there's always going to be a problem with, even in an initial interview, if you want, I'm going to ask you 51 questions that take 10 seconds apiece or longer, and you're using up all of your time to just ask this generic history when, you can screen and bounce and cut off huge portions of the issues really quickly and spend more time on stuff that matters, actually delve deep and not just going broad. But that's always going to be in contention, those two pieces. I mean, you don't have all the time in the world. So that was the 1960 time frame. So 1970. So kind of a typical mental status exam by 1970 looked kind of like this. So it's looking more normal, more like what we see now. You have appearance, behavior, attitudes, activities, kind of thing. Historical information about the patient gets put in there. You get a kind of speech, thoughts, mental activity stuff, cognitive functioning. The disorders of perception, so psychosis stuff, AVH, delusions, affects, neurological deficits, and then for some reason they loved IQ stuff, like Wechsler and all that stuff in America is just like white people smart, black people dumb, and psychotic with schizophrenia, or more 2-to-1 ratio, like all this dumb stuff they did back then. But so they're separated for some reason. I don't know. Adaptive capacity, which kind of interesting. We talk about that at least at my institution, but as a general thing we pay attention to, right? Not just ADLs, but that's kind of an interesting topic, useful for us. And then I was finding people, they were kind of like the evolution of the mental status, past and future, trying to do the same thing I'm doing right now back in the day. So in 1970 paper, researchers were noting that Adolf Meyer, so here's his little book again, the 1980 guy from Johns Hopkins who got to be super famous. Researchers were noting that Myers was blending of psychiatry and psychology based on his own philosophy did little to improve the initial problems with psychiatry as a science. His version was still closely followed 50 years later. So I don't know, those people with factor analysis and stuff, they were still following his format. I'm going to write your life story or just give up and walk away. But overall, the MSc was still fully subjective, overly inclusive, and impractical for note writing. So that's how people were still being taught and what was going on. 1975, we end up with a little mini version of the MSc. So that's they just started taking the cognitive aspects out of it, make it a little simpler, and the cognitive sections should be really standardized or routine because they're done in a certain way. And here's from the MMSE, the famous apple, table, penny, and why you're still told that stuff and asked. I mean, you could say blue, cow, orange. It doesn't matter, right? You should pick things not in a category or whatever synonyms. But it's like there's nothing special about these words. All the neurocognitive stuff's that way. So don't feel trapped when we get to that section about 3 lectures from now. It doesn't matter. It's all fake to some degree. It just got tested. But yeah, so they started shortening it, give a real part of the mental status exam, more neurology and in the hospitals and stuff. But then psychiatry latched onto it and, regularly did that and MOCAs and stuff for the next 50 years. So this was a 1979 paper, which was about the origin, use, and content of the mental status exam. So still a big issue. People up to 1979 are like, what the heck is going on with this whole section of psychiatry? This chunk of your note, what are we doing? So there's drugs nowadays, lots of medical schools. We're DSM-3, we're not up to 4 yet, I don't think. So there's a common assumption, this is the quote, there's a common assumption that psychiatrists mean the same thing when they speak of the mental status examination and use it for similar purposes. However, the clinical utility of the mental status examination and its teaching purposes are questioned after an overview of the literature and a survey of the psychiatric training centers indicated lack of agreement regarding its purpose, content, and focus of measurement. It is suggested such lack of uniformity contributes to the lack of diagnostic consistency in psychiatry, and that consensus on goals of mental status examination is needed before a more standardized instrument can be implemented. We're bad at diagnosing stuff accurately. People still latched on to psychoanalysis reaction stuff previously. In 2000 or like 99, there was a big famous study where using the book, same DSM-4, they took like schizophrenia and manic patients. They had just thing to read. That was it. And they did like 8 patient case studies or whatever in a bunch of places in England, did a bunch of them in the US, and like 30% disagreement on the diagnosis. So we aren't doing so great on what we're using this for. 1980s. So papers indicating the mental status exam is not followed in any way as written. So they're still complaining. They're like, what are we doing? Nobody's doing this. Textbooks are starting to be more regular at this point, and here's kind of what they're showing they look like. Very, very close to what they look like nowadays, right? Still a few too many sections, maybe not enough. I don't know, but so it kind of looks like they do now. So levels of consciousness, I guess LSC. If you're talking to the person, I don't think you have to write that down, but that's okay. Alert and oriented times 4, right? That's the answer. So appearance, general behavior, speech, motor activity, affect, mood, thought, perception, right? It's got the pieces. The last thing I could find about people even challenging the mental status exam, or what is it, how does it work, was in 1985. And they were basically pointing out it didn't work in children or old people. 1990s, textbooks just go pop, 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 coming up everywhere. Multiple editions, they're copying and pasting each other. There's not a thought among them. And some ongoing research with the mini mental status exam is being used. Then you get into the 2000s, more textbooks, more cut and paste, more no critical evaluation concept anything, just cut and paste, got to be real. Look at all these textbooks, cut and paste. And then the last 10 years or so, 1010s up to early 2020s, just more textbooks, the AMA promoting, you should just role play them out and do teaching. And I found like journals where you could get free fake patient stuff to set up, for medical students and stuff to see them. They started making specialty versions for like autism, deaf, dumb kind of stuff. Study books for the mental status exam, videos teaching it, just more content. See, they never addressed or did anything about the first pieces. There's still no definitions that are actually like meaningful. They're not picking words to where we make sure that the words are separated and don't overlap to where you can't tell the difference. We're not picking a standardized set of actual pieces of the MSE. None of that. None of it. So kind of the take-home message is the mental status exam, I'm sorry to say, it's arbitrary. Not that it's useless, but what's in it is arbitrary. Just because you're used to textbooks existing, they don't increase the truthiness. They don't. Especially in our field. Our field is the redheaded stepchild. We're working hard to be a real science, a real field that really helps people in an accurate, effective way. And the mental status exam still doesn't it's super necessary for our objective information, but it's not a real thing. It's not like this is the way it's done. That's why you've never seen it in an official way. And when you've seen it in an official way, and they make it, maybe people get mad about this video, and no, I'll never be that important, but and they actually try to officiate it in the APA or something. It's made up. They just pick some things, those are the topics, and they run with it, and now it's real because famous Hopkins, whatever. I'm never going to get to work there, am I? I don't have anything against John Hopkins. The mental status exam is for your objective information. Cut and paste into it if it's not important. If it's important, you need to write there. You need to actually write stuff down because you actually care. But know that everybody's going to scan it or skip it. They're not even going to look at it on follow-ups because they just know we all cut and paste and it's a lie. You should use widely understood terminology and language. If you aren't sure, just write it out in plain language. Don't be fancy. I mean, you write down circumstantiality, and I'm looking at it, I'm like, they got a circumcision? What does that mean? Like, we're idiots. I'm an idiot. Just, if it needs to be written out in plain language, you probably should. Alrighty, so that's been the first video of several on the mental status exam. Let me know what you thought about it if you want me to change things for future videos, and I'll kind of keep redirecting and make them better over time. So, alright, take care.